So we're going to bring up our next presenter. Getchen Newman is the director of the Wayne State University Adult HIV Program and the medical director of Tolan Clinic, the largest HIV clinic in Michigan. Originally from a small town south of Boston, she trained in internal medicine at Emory University in Atlanta and in the infectious disease at University of Washington, Seattle. Outside of work, she and her wife, Kira, are proud mommies of their 2-year-old son, Asa. We bring to you Dr. Getchen Newman.
So as LaDon said, I'm an academic clinician, which means that when given the opportunity to PowerPoint, I will PowerPoint. But in truth, I wanted to take this opportunity to introduce myself. This is, for many of you, not the first time that you've seen me, but for some of you, it is the first time that you've seen me. So I am, I have big shoes to fill. I see Dr. Cohn has just walked in. I want to, right next to Dr. Cohn, will you actually stand up? Will you stand up? The enormous privilege over the last 3 years to be mentored by John Cohn, who is the outgoing director of the Wayne State Adult HIV Program, known incredibly well to this community for more than 30 years of service to the HIV community and more than 25 years of service here in Detroit. He and Larry Crane and others built the Tolan Park program, starting with the earliest clinical trials on AZT back in the 80s and moving all the way forward to the modern era and to the has been an incredible part of the community that we are all embedded in right now. And so, thank you, John, for your amazing service. Skip is sitting right next to him. And Skip has been an enormous part of our service. I can't actually introduce you to Skip's successor because that is still locked in Wayne's world HR. And so we have yet to hire a leader of our psychosocial team. If you know anyone, let me know. But I was asked to talk about two things. One is the future of Tolan, and I'll get to that, but I also want to talk about monkeypox. And I think monkeypox is incredibly resonant to this community. Next slide, please. For a number of reasons that we'll get to. But let's just talk quickly about where we're at. Next. So, it's a new name, you guys. How many of you guys remember Hansen from the 90s? Cast your mind back to 1996. We are no longer calling it monkeypox. We are calling it mpox or mpox. The jury is out on how we pronounce it. But for anybody who is my age, and I will confess to you that I am as old as HIV, it is mpox. So this is an important change that the WHO came out with last week. Though monkeypox does not actually have racist origins, it's because the virus was first found in a bunch of monkeys, literal monkeys. It has been used in incredibly racist ways, and so they have changed the name. The M still stands for monkeys, so win some, lose some, but we'll get there. Next slide, please. This is where we're at in the United States as of this morning. We've got almost 30,000 cases and a total of 15 deaths. And monkeypox, much like HIV, has not been evenly distributed throughout the country. These are not case rates, these are actual total cases, so they very closely track how many people live here. Not a lot of folks in North Dakota, so not a lot of monkeypox in North Dakota. Next slide. And we see here in Michigan, we've got 383 cases as of today. And this really has been an epidemic concentrated in Southeast Michigan and concentrated right here in Detroit, where the overwhelming majority of cases have been in Wayne County, Oakland County, and then the Health District of Detroit. Yep. When we look at the country, this is important. We see that it was a big peak over the summer. quick, sharp uprise, and then the long tail that we are still in today. But Michigan's numbers have been different. Yep. Is that moving? Michigan, we never had a big peak like the rest of the country did. Our numbers look more like a roller coaster. Up and down and up and down and up and down, and now we're coming back up again. And so how we've had to intervene with monkeypox has been a little bit different. We've had a much slower roll to our epidemic, and it's been much more steady. So we never got overwhelmed, although I think Shira Heisler at the STD clinic might disagree with me about that. In the hospitals, we never got overwhelmed the way other places did, but we've also never had that big retreat. We're still seeing a pretty steady number of people with monkeypox. Next. Like HIV, monkeypox has followed a very predictable pattern of disparity. So if we remember HIV in the 80s, it was primarily considered to be a white gay men's disease. And then in 1996, everything flipped. And the majority of people infected with HIV were black. And a larger percentage were women. And we saw that happen very dramatically and very consistently and persist through moving forward. So marginalized communities were more heavily impacted by HIV. Similarly, over a much shorter time period, monkeypox has done the same thing. When monkeypox was first discovered, like 8 months ago, you guys, let's cast our minds back not that far, it was primarily amongst white gay men in the club circuit, specific party circuits. But if we go to the next slide, we see that very quickly, we have a majority African American disease here. So mirroring what has happened with HIV, we see multiply marginalized communities more heavily impacted as time has gone on. The other thing that I think is interesting for us all to think about is the age of people with monkeypox. When we think about HIV acquisition, we're really talking about people in their early 20s for the most part. For monkeypox, we're really talking about people in their 30s. I don't know what that means, but it's interesting to note. Next slide. When we look at vaccination though, and this is the Jynneos 2-shot vaccine, we see the inverse of cases. More cases in African Americans, but much more vaccination among white Americans. So this mirrors all of the racial disparity that we saw when we talked about early access to HIV treatment. Much faster uptake amongst white people with HIV than amongst black people with HIV, largely mediated by access to care. So this is, to me, as someone who has spent her working life working with HIV and her entire life watching HIV, is really troubling that we are recapitulating all of the stuff that we know about that happened with HIV. The same communities that are disproportionately affected by HIV, even up to this day, have been disproportionately affected by monkeypox. The question is, have we learned our lessons? Right? How many think pieces have you guys seen in the newspaper and the magazines? Have we learned the lessons of COVID for monkeypox? I don't actually think that's the right question. I think the right question is, have we learned the right lessons from HIV for monkeypox? Have we learned that we need to listen to our community members about where and how they want to receive treatment and to receive outreach? Maybe. Maybe. Have we learned about how to build trust among communities in order to make sure that when we do finally make it somewhere, people are ready to say yes to a therapy that's offered? I think that's been really complicated by COVID. But I would say we're also not doing our job coming from the biomedical health standpoint out into the community. Next slide. So steps we've taken in Detroit, and I really want to credit the Detroit Health Department, MDHHS, and in particular Shira Heisler at the Detroit STD Clinic for really spearheading a ton of this work to make sure that we were doing as much as we possibly could to reduce disparity in access to Jynneos vaccine. So we have done pop-up vaccine clinics at night at spas and at clubs to reach people where they are so that folks don't have to come in. We were able to stand up very quickly high throughput vaccine clinics so that anybody who wanted to come, regardless of insurance status, regardless of anything else, was able to come in and get vaccinated quickly. And we used SEMHAC to do a bunch of our messaging, so thank you to all of you here. Has it been enough? No, but I think that we have done a decent job. here in Detroit in getting things out. A long way to go still though, particularly as we think about that long tail. Next slide. That there have been almost no fatalities due to monkeypox, very, very few, only 15 in the United States. That's an incredibly lucky fact. Much lower case fatality rates than historically. So it could be like syphilis and just kind of simmer along in the background, which would be terrible. It could be cyclical. So we could see, you know, cuffing season arrives, monkeypox arrives, summer party season arrives, monkeypox arrives. Or it could be something totally different. I think that it is unlikely that we will break monkeypox transmission in the United States. I don't think we're going to get rid of it the way that we had initially hoped. But we could. I'd love to be wrong. I'd love to be wrong on this. So let's move on to Tolan and what is going on at Tolan Park. So we have, next slide, a whole bunch of new people I'm going to introduce you to. So I'm the one all the way on your left. As per my introduction, I am gay, I am married, I have a 2-year-old son, and that is a dramatic change from prior leadership. I'm a woman, in case you missed that. But fundamentally, the goals of the program and the program's approach to working with the community are going to remain. Everything that you know and trust about Tolan is really where we're going to start building from. We have an incredible legacy of trust and engagement with the community, and I know that myself, Lauren Tulleru, and Amanda Allmacher, who's taking over at Maytech for Mary Rose Forsyth, are very committed to maintaining that and building and strengthening those relationships. So though we are different people, we have very similar values. Lauren Tulleru in the center is junior faculty who's joining us from our own program here, and so she's the assistant director over at Tolan. You'll see her. She's about to become a mom, so it's a whole bunch of young moms. And then Amanda Allmacher is taking over Maytech, the Michigan AIDS Education and Training Center for Mary Rose Forsyth, who is stepping down next week after 30 plus years of service. So a generational change, as Odalis was talking, as she was talking about 40 years of work in the HIV field, I was like, we have a new generation coming. So it is an incredible privilege and an honor to be here. It's an incredible, the shoes are very large, and we will have missteps and hopefully be granted grace by the community to correct errors and move forward. But we're excited about where we're going. Next slide. So where are we going? Next slide. Maytech has done a couple of exciting new things. One is an HIV Echo program, which is really about building a community of providers. One thing that we know in the HIV world is that outside of big places like Ford and Wayne, there's a lot of turnover in outstate Michigan amongst people who provide HIV care, and we want to slow that down. And one of the ways to do that is to create a community of providers, so we've done that through an Echo program. Next slide. And then we have, there are existing collaborations and real opportunities to collaborate with the University of Michigan around hepatitis C. Dr. Cohn and others from Wayne were instrumental in the We Treat Hep C program from MDHHS, really focusing on eliminating hepatitis C. And the hepatitis C HIV syndemic are very tightly aligned. And we hope to build on that with the University of Michigan. Next slide. And then we have a new perinatal collaborative, which has been going on for the last 10 months or so, and is a way of us really digging in and supporting women who have HIV, who are having babies in that prepartum, peripartum, and postpartum period, so that we can ensure that babies born exposed to HIV are linked to care, moms have suppressed viral loads at the time of delivery, and then are linked back to HIV care after they deliver their baby. So all of those gaps that we know women fall into, we're trying to put a net under them. So thus far, the most success has been really actually this interdisciplinary, multi-institutional call around once a month, talking about women who we have concerns about, sharing resources, sharing ideas around them, and making sure that we're providing women with every possible support that we have. Next slide, please. Yep. The next big thing is research. And I am so glad that Odalis talked about participating in clinical trials in her talk. Because we have not done clinical trials research or really much research at all at Tolan in the last several years. There's been a ton of clinical demand. And I know from my experience that when you say research to a group of folks, everybody starts looking at you like, I'm not going to be that guinea pig. No ma'am. I'm not going to be that guinea pig. And so I want to spend the last couple of minutes that I have talking with you guys, because you guys are such leaders in the community, about why research is really important, why it's important that research gets done in places like Detroit, and what the community's role in research is. So why does it matter, right? Why does it even matter? Let all those guys in New York and Seattle and San Francisco, let them be the guinea pigs for all of this. Let them try it all out. And it matters for a couple of reasons. One, clinical trials are one thing about drugs, and people can decide whether or not they want to do that. But a lot of research that goes on right now isn't actually about whether a new medication will work or not. A lot of research that goes on right now is, how are we going to reach folks that we're not reaching? How are we going to bring that young guy in who doesn't have HIV yet, but is at risk, and make sure that he or she or whomever it is, that they're able to make decisions that are right for them and right for their situation, and then move that forward. We come up with these programs, the city of Detroit comes up with these programs, the state comes up with the programs based on research that's done elsewhere. It's done in Atlanta, it's done in New York, it's done in Seattle, it's done in San Francisco, it's done in Birmingham, Alabama. None of those places are Detroit, right? None of those places are here. And unless we develop programs here, located here, for people who are here, living in the circumstances that we have here in Detroit, the whole national conversation is going to not include the experiences of people here. And the field is going to move without our voice. And so by participating in research, what we do is we make sure that our lives count, and that our experiences go on to form state and national policy, because that's how that policy gets made. And so I really want to flip this script. All right, I can't believe I just said that. It's like 1995 in my mouth. I really want to change this paradigm, where instead of thinking about research as people who are not like us coming in, studying us, putting us under the microscope, and then walking away and talking about us behind our backs. That is not what we want to be doing at Tolan. That is not what we want to be doing at Wayne. And that's actually pretty shitty research, truthfully. What I want us to think about as a community is, what are the questions that really matter to us? What are the questions that we haven't answered, that when Dr. Newman goes on PubMed and she's like, this is functionally Google for scientists, she's typing, and she can't find the answer, what of those questions matter to people living here? With HIV, without HIV, gay, straight, trans, gender fluid, intersex, pansexual, you pick your adjective that you care about, your identity that you care about. Those are the questions that we want to answer together. The old school term for this is community-based collaborative research. And let me tell you, I have a lot of training in community-based collaborative research. You can get a master's degree in it. I don't have that, but it's available. What I want you guys to think about this, and when we start asking you guys to participate, and not just the thoughts about being a participant. I want you to come back to your provider, and I want you to come back to me and Dr. Tularu and Amanda Allmacher, and I want you to say, I have questions that I want you to help me answer. I have this program idea that I want to do, that I want to set it up so that we know if it works. And so that we can tell people everywhere else, this is the cool shit we're doing here in Detroit. That's what research is. That's what this kind of research is. And that's what research that is going to matter, and why your voices matter when we're talking about doing research. With that, at the end of every talk, I take questions. So I'm going to actually just stand up here and let you guys ask questions for a couple until Rhonda makes me get off the stage. Are there questions? Are there concerns?
I have a concern.
Yeah.
So, James Schneider recently relocated to Detroit after a year on the road. And so, the question is really about your data.
Yeah.
And it's going to come off aggressive because I've been through quite a bit of stuff.
I'm here.
How do we...
It's a question about data that's going to be aggressive.
And the population.
And population. Mm-hmm.
So, if you take a look at Hillcrest in San Diego, and Silver Lake or West Hollywood, travel to DuPont Circle in Washington, D.C. You go to Midtown in Atlanta, or you go to Queens Village, where it's very obvious in Queens Village in Philadelphia. There is no gay population. It is gone. And so, I've been through a very unfortunate circumstance where things stopped by a number of things that were going on. But it's very clear in Queens Village, of course, murderers, my safety. There was an attempted murder in New York City, and I had to speak to the New York City Police Department, and they refused to take a police report, telling me that I had reached the wrong level on the phone. So it sounds absurd, but I spoke for 4 hours with them on the phone, and realized that what I perceived was true. Right? There's no safety there. If you look on Google Earth through Washington Heights and through Harlem, all of the cars in this area are parked in front of Tigers, right? If you remember Giuliani, right? We went through a cleanup in New York. I lived in New York for several years, and it changed with his urban renewal project, right? Crime off the streets, including ticketing for cars and stop benefits, so reducing petty crime, right? And now that's at a height in New York. And so not only gay population are missing, but so are Latin American populations, the Black population, Harlem. So how do we trust any of the data now when some of the key populations are missing their people, right? I reported this several times.
Yeah.
Let me call them FBI here, to me, and they won't take a report, right? They will only ask you what crime has been committed. So when you enter, so to me, we're at a catastrophic collapse of public safety and public health. And we've got these key things going on, the two pandemics that are hard to trust.
Yeah.
Like, how do we trust data and how do we rebuild trust when it looks like public safety will keep us safe?
So how do we trust the data when we see with our own eyes that gay neighborhoods have been hollowed out by people with dual strollers, right?
Not hollowed out. Like,
How do we trust the data when we ourselves are marginalized in that data? And how do we know that it's true? And a large part of that really is, there's two questions in there. There's the how do we trust the data that comes from the government? I can't answer that question, I'm not in charge of it. But how do we trust the data for the science that we're doing and the questions that we're asking? And that's about participation and making sure that we, as the people who are conducting the research or who are gathering that data, are being transparent with you all about what data we're gathering. And here's the question that I'm going to ask you to ask everybody. Why you want that piece of data? Why does this factor about you matter to what they're answering? And if they can't answer that question, they shouldn't be collecting that data. But I will make this promise, before I collect a single piece of data about anybody, we're going to be able to explain to you why that's important to the larger question that we're asking. Okay? Other questions or concerns?
Dr. Newman, over here.
I have a question.
Yes?
You spoke about research,
Yeah.
and that's very important. But can you speak to the audience about the misunderstanding of research being performed in the African American community versus a Caucasian community?
Yeah.
The misunderstandings that we still have and see today, based upon the data that you talked about with HIV. It's predominantly African Americans who live with the disease state now.
Yeah.
With Monkey Pox, how that data is showing the difference where it was Caucasian, now it is for African Americans. Can you please educate the audience on that and the importance of research and participation?
So there is a long history of research being done in and on African American communities in the United States. And anybody who tells you that that's in the past is straight up lying to your face, right? It is a challenge. And part of how we part of how we do and correct that is by doing what I'm doing right now, which is standing up here and telling people why it's important, why research matters. And part of what happens with things like HIV and monkeypox is that once it goes into a marginalized community, into a community with less power, people care about it less, right? It's less in the news. It's less talked about. It doesn't mean that it's not affecting people. It just means that as a society, we have the mistaken belief that if it's not in my face, it's not there. And part of how we pull it back to the front is that we do science about it, and we talk about it, and we are able to answer those questions by asking those questions. The questions that we ask and the work that we do defines what's important to our society. And I care deeply about this community. I am in many ways a member of this community, and so it is important to me that the questions that we ask reflect what is important to this community, because by asking and answering those questions, we elevate the importance of that community.
Yes, as far as MPOX, as you call it, we're trying to find out more of where did it originate from.
Yeah.
Black Sabbath, white Sabbath, is it coming from overseas? Where is it coming from? We need to know more about this and try to go somewhere where we can study more about it, like we had to do HIV.
Mm-hmm. So that's a great question that I'm happy to answer. So this is the rare time when I can actually give you a true answer. We know exactly where it came from. Monkeypox, Mpox as a virus. The virus itself is related to the smallpox virus, not the chickenpox virus, despite the names. And it's what we call a zoonotic disease. That means that it lives all the time in animals and occasionally crosses over into people. And so those animals are predominantly rodents that live in West and Central Africa. Squirrels, literally squirrels, and rats and dormice and little things like that. When people get in really close contact with that, we have had for many, many decades, probably hundreds of years, cases where a person has gotten infected or has contracted Mpox.
Quiet. Acquired is the new word.
Acquired.
Thank you.
Thank you. Has acquired monkeypox from contact with a rodent. It can be as simple as getting bitten. And then develops the rash and passes it on to people that they are in close contact with. And that just means household contacts, historically. Historically, this is the people that you lived with. It was passed on through actual touching of the lesions by the people taking care of you, with your saliva, maybe, and with bedding. And so people taking care of people who had acquired Mpox, thank you, from the back, were at the most risk. For the last 10 years or so, researchers in Lagos, Nigeria have been trying to alert the world to this other mode of transmission that they were seeing in Nigeria, which seemed to be sexual or intimate contact transmission among men who had sex with men in Lagos. Truthfully, people didn't pay much attention to it, to our detriment. Okay? At some point, probably in April or May, a traveler from Lagos came to Europe and was pre-infectious. He was in the incubation period. And then we started to see cases pop up. Because we live in a globally connected world, and because there is that incubation period with Mpox, by the time we all woke up to what was going on, it had spread significantly. It was June, it was Pride, it was party season, it was circuit party season, and it wasn't clear how we were going to get ahead of it, and that's what happened. It's honestly, it's very well worked out. We have all of those people have been identified by public health. They've, for the most part, all recovered. But it really points to an important fact, which is that had we paid attention to people in Africa getting monkeypox, getting Mpox, acquiring Mpox, for the many, many years, had we distributed vaccine years and years and years ago and had that ongoing, this might have never happened. As a reflection of where the world places its priorities and where the rich world places its priorities, we didn't pay attention. And now this is where we are. Does that answer your question?
Yes.
This is the last question.
Y'all know y'all say the best for last. Hi. So quick research-ish question. Just overall in general, along with MPOX and HIV and such or whatnot, what all is it gonna take to have better, stronger conversations with providers and making sure that trans men are accounted for in this data that you all keep collecting?
Oh, sing me a song.
I mean, I'm a great singer, so by all means, but also come with a price. But no, seriously, because
Yeah.
I'm really still stuck in this corner by myself. Been dealing with this for almost 6 years now, and every agency that I've gone to will turn around and say, oh yeah, come on. But really it's for the benefit of them to keep getting funding to say that they help trans people as a whole, but yet there's no solution or resources for trans men or gender nonconforming people who are assigned female at birth. So,
Yes. I wish I had that answer. But I share your angst. But I will tell you, as a woman married to a gender nonconforming woman, it pisses me off on the regular. The fact that trans men and gender nonconforming people who are assigned female at birth are woefully underrepresented in the data, like shockingly underrepresented. Some of that is in truth because there are fewer in number. Absolute number is lower. Part of that is because the rate of HIV acquisition is lower, not zero, and the erasure is very real, but it is smaller. And a lot of that has to do with the word, like just the God's honest truth, which is misogyny. And I don't have a solution for it, other than to say that it is incumbent on us as providers to be welcoming. And it is incumbent upon us to make sure that when we ask questions and when we do research and ask these research questions, that the experiences of everybody are included in both the design and the analysis of the data. And so I will actually say that this has been something that I have been working on and raising at forums for a long time. And the answers that I have gotten from funders are really unsatisfying. The only thing that I can tell you is that I see it, I'm completely aware of it, and I share your frustration with it. It's something that we are not going to erase in anything that we do. And for those of us who live in that world with other people assigned female at birth who are non-gender conforming, it's also incumbent upon us to continue to raise our hands. So thank you. It's the question, asking the question over and over and over again, that's how we move the needle. Thank you all so much. I have clinic in an hour, but we'll be here if there's anything else. Thank you.
Give Dr. Getchen another round of applause, please.
Yes.